Hello again, everyone. So this section should be quite short. It is about diseases of the spleen and the thymus. So here is the gross anatomy of the spleen. Normally the spleen should not be palpable, but when it is enlarged, we may be able to, it may be palpable. It may be palpable at the left upper quadrant of the abdomen. And the histology of the spleen, we can see two different areas: white white pulp, white pulp with splenic nodules, and red pulp, white pulp and red pulp. So in the white pulp area, we will see the zone of lymphoid follicles, which is for B cells. And there is another special area around the arteriole. It is called PALS, periarteriolar lymphoid sheath. Periarteriolar lymphoid sheath. This area is for T cells. This is white pulp. In the red pulp area, we will see cords of Bilroth. We will see splenic cords. We will see a lot of red blood cells, white blood cells, macrophages. It is a zone for blood filtering. Our blood will be filtered through this area. In the spleen, there are two circulations. The fast one, or closed circulation, and the slow one, or open circulation. The fast one, the blood that enters into the spleen will go through that quickly to the vein. Will go quickly and to the vein, so there is no filtering. The blood just passes through the spleen quickly, and the most of the blood entering into the spleen will go into this way, but only a small proportion of the blood will enter another circulation, which is slow open circulation. The blood will exit the capillaries and then will go through the cords of the red pulp. And in the cords of the red pulp, there are a lot of macrophages that will screen for abnormal red blood cells, screen for abnormal organisms, abnormal particles. So it is will be strictly filtered. The blood will be strictly filtered by these macrophages. So the functions of the spleen include phagocytosis, antibody production, hematopoiesis, and sequestration. Spleen is very important for eradication of many organisms, particularly organisms with capsules, because these organisms require opsonization, and when they are opsonized, the spleen will take them up. The macrophages will take them up and eat them up and digest them. Splenomegaly has so many causes. So splenomegaly means the spleen enlargement, maybe with or without hypersplenism. So the causes include hypoplasia, maybe from autoimmune diseases or infections. These conditions will cause expansion of the white pulp, the expansion of the red pulp. The hyperplasia of the red pulp includes extravascular hemolytic anemia, This one, the most important example of this one in Thailand may be thalassemia, or hereditary spherocytosis. And sometimes the hyperplasia takes place within the sinusoids, which is seen in the conditions with extramedullary hematopoiesis, for example, in the myelofibrosis. And these conditions are hyperplastic conditions, but sometimes the splenomegaly is splenomegaly results from infiltrative diseases, for example, metastatic non-Hodgkin lymphoma, primary amyloidosis, or lysosomal storage disease, or vascular congestion, for example, portal hypertension, resulting in hypersplenism, resulting in pancytopenia. Infarction can be seen in the spleen as well. For example, those with infective endocarditis or atherosclerosis of the celiac circulation, celiac trunk, or splenic artery. So, resulting in infarction. And just recall that this is one example of white infarct, white infarction. White infarct is seen in solid organ with arterial occlusion, and the organ needs to have only single blood supply, right? Or sometimes the patients have splenomegaly and with decreased blood flow, for example, in heart failure. So the spleen may undergo infarction. Splenic tumors are quite rare, may be metastatic or maybe different benign tumors. Congenital anomalies of the spleen can be seen also. For example, asplenism, splenic hypoplasia, or presence of accessory spleens. This image shows accessory spleens, so cute, tiny spleen outside the big spleen here. And splenic rupture is one common condition in those who have blunt force trauma. So when there is splenic rupture, the main treatment is splenectomy. And sometimes the rupture results from acute enlargement of the spleen in the acute splenic congestion, acute splenomegaly. And the last organ, the thymus, pathology of thymus. Thymus is located in the anterior mediastinum, anterosuperior mediastinum here. In adults, it is quite atrophic. It reaches the largest size during the adolescent age group. And the thymus originates or develops from the pharyngeal pouch 3 and 4. So it can be divided into the cortex and the medulla. And it is composed of these lymphocytes, which are called thymocytes, and also thymic epithelium. We may observe hazel corpuscle here, like this. So from thymic epithelium. And development disorders include hypoplasia or aplasia. And one condition that you must know is the George syndrome. The George syndrome, or nowadays we tend to eliminate a specific maybe people's name. So we may call this condition chromosome 22q11.2 deletion syndrome. It is important because you will hear this name again and again because it is a cause of cardiac anomalies, it is a cause of facial anomalies, it is a cause of thymic hypoplasia. So the patients will present with immunodeficiency. It is associated with cleft palate. It is associated with hypocalcemia from hypoparathyroidism. So this genetic disorder is quite important because it is associated with so many systems. And for cystic lesion, thymic cysts can also be seen. Thymic hyperplasia is a reactive B-cell lymphoid follicles within the thymus. It is seen in chronic inflammatory and immunologic states, particularly myasthenia gravis. 65 to 75% of the cases of myasthenia gravis will have thymic hyperplasia. If you remember in the lecture on neuropathology, I mentioned about myasthenia gravis, right? And myasthenia gravis must be distinguished from Lambert-Eaton syndrome, myasthenic syndrome, right? So for myasthenia gravis, the association is with thymic pathology, not necessarily thymoma, any thymic pathology, and the most common thymic pathology that can be observed is thymic hyperplasia, not thymoma. And all the patients with myasthenia gravis who are detected to have big thymus need to do thymectomy, and thymectomy can save many patients' life. It can save life of many patients. And thymoma. Thymoma is not a neoplasm of thymocytes. It is not a neoplasm of lymphoid cells, T lymphocytes, but it is a neoplasm of thymic epithelium cells. Thymic epithelium cells. It is seen in adults more than 40 years old. Thymoma can be divided into three types: non-invasive thymomas or totally benign one, benign behavior, benign looking. Invasive thymoma, the cells look good, but they invade into the surrounding tissue. And thymic carcinoma, the cells look ugly and behave badly as well. So the clinical feature is maybe mediastinal mass. The location is ankylosuperior or ancilia mediastinum. Right? So ancilia mediastinal mass, one common cause is thymoma. And some of those who have thymoma will also have myasthenia gravis. So if you remember myasthenia gravis, the patients present with weakness, and the key feature is the dramatic weakness after repetitive stimulation, right? It will repeat again and again, and the stores of the acetylcholine are depleted. There is store depletion, so activation will release no acetylcholine because no acetylcholine left. After repeated stimulation, the patients will develop profound weakness. And also other paraneoplastic syndromes are also possible. It's really the end. Congratulations. Okay, I hope that you have enjoyed my lectures. They are quite long, but I hope that you have enjoyed it to some degree. Okay, see you. Bye bye.